Hello, I am Dr. J. Hydren, the Senior Director of Clinical Research here at HealthTree Foundation. And we are so excited because we had a abstract accepted as a oral presentation at ASH 2024. I got to present these slides there, and now I'm doing a follow-up recording so that you can learn about it. So here's the slide. We think there's some good findings in here, so please let other patients, physicians know about this. So the title of this is Patient-Centered Care in Hematology: How Side Effect Severity Influences Decision-Making Autonomy in Relapse Refractory Multiple Myeloma. Here are the authors and their affiliations. So quick background: the importance of patient preference. Understanding patient preference and decision-making process is vital in managing relapse refractory multiple myeloma. There are many options now for treatments, and those treatments might be better for different patients in different situations. Here with shared decision-making, it's a key element of the patient-centered care, enabling collaboration between the patient and healthcare provider to align treatment choices with health and quality of life goals. And that's really important. And we'll find in the study that it's more than just those two individuals. It also includes peers, fellow patients, and caregivers as well. The study focused on exploring how perceived severity of treatment side effects impacts patient decision-making autonomy and communication patterns between patients and providers. And overall, this will offer valuable perspectives on decision-making practices in hematology. The study scope was absolutely enormous. We did 11 domains. I think the first few are really interesting to pay attention to, and that's what I'll go into. I'll also describe what the whole study was all about. So treatment-related factors, patient-related factors, myeloma disease-related factors, education, awareness, and understanding, patient education resources, who discuss treatment options with the patient, treatment decision satisfaction, clinical decision-making experience, clinical trial considerations and participation, doctor-patient relationships, and decision-making in the age of new therapies. We did this in 30 questions. There was 174 factors, so absolutely enormous. And questions 2 through 21 were asked twice. One at first change in treatment and one at their most recent change in treatment. For the most part, the study will look at that first change in treatment unless I otherwise indicate in the slide. It was deployed on HealthTree Cure Hub. Here, if you're a patient, you can sign up, register. We have studies going on all the time. I try to get several studies out each quarter for you to participate in. It's very easy. You can also connect your medical records if you like, and that allows us to do a deeper dive. It's all we de-identify all the data, we clean it out, we harmonize it, we create a high quality data set to help other patients like you make a better treatment decision. So this is how the patient saw it. We also sent emails, put it in our newsletters, and did some banner ads to get people to participate in this study. At the time of this data poll, there were 784 multiple myeloma patients that took the survey. 333 that took the survey were had one or more treatment changes, so they were relapsed refractory patients. The subgroup analysis, this is really important, pay attention now. 54% within an N, so a sample size of 181, rated side effects as very or extremely influential, and 46 or 152 patients rated side effects as somewhat, slightly, or not influential at all. So VE, very extremely, that's one group. That's a group of interest. And then we have somewhat, slightly, not influential as SSN, and you'll see that in the graphs, figures, tables, etc. So demographics, largely they were similar with the exception of gender. 60% The VE group was made up of females, whereas it was 47% in the SSN group. So age was similar. Overall, average age 66 at the time of survey. That's not the age of diagnosis. That's the age at taking the survey. Mostly white, 6 and 4% black. Hispanic was 5 and 6%. And then there's a breakdown of the college. So mostly that graduate or professional school. So professional school meaning that it was a degree they had to get in order to do the profession that they were in, whether that was a proper university or trade school was up to the patient. So understanding of side effects. Remember, these patients are very concerned about side effects, so that VE group does indeed rate themselves as having a better understanding of likely side effects for the treatment options. That was 3.9 versus 3.6. It's important in research to understand if there's a relationship between some of these variables that we measure, even if it's just a survey. And here we looked at the level of understanding of likely side effects of your treatment options, and then that variable that we did the dichotomous split on. So this was the influence of side effect severity on treatment options, and indeed there was a significant, you see that p-value is 0.004, our threshold is 0.05. So it's quite significant. And the R value is weak at 1.64 for survey type research. A lower R value is still acceptable and saying that there is a relationship. In physiology measures or medical measures, we like to see that higher. So it depends on the data in what we call the taxonomy of the correlation. But here, weak relationship significant, showing that there's an underlying construct for this idea of side effect severity and how a patient is influenced by that to the level of understanding. And again, here we did the level of understanding of likely balance between effectiveness of a therapy and possible side effects. So that risk-benefit ratio, commonly said, and this dichotomous influence that we use. Here's the continuous scale again, influence of side effects, severity on treatment decisions, almost 0.2, and then look at the p-value, 0.0006. Okay. Treatment-related factors, here are the ones that were greater in that VE group, very extremely group. So treatment frequency was really important to them. Treatment availability, timing clinic. So sometimes that's returned as time toxicity, supportive care requirements or needs. Having that FDA approval of the therapy was more important for those patients in that VE group. They want to have more understanding, more data on that potential experience they're going to have. Patient-related factors were mostly significant. Here, quality of life, number one, 3.9 versus 2.9. Very important in that VE group to maintain their quality of life that they can get to. Ability to take care of myself during treatment was higher. Existing health conditions that could be made worse. Their emotional state and anxiety. And out-of-pocket costs or their financial status or insurance coverage were all higher in that VE group. Additionally, within patient-related factors, the same as the last slide, ability to continue working on treatment, ability and willingness to travel to a treatment center, ability to take care of others and daily responsibilities while on treatment, and their current physical ability or frailty were all more influenced. Really seeing that need to maintain quality of life, doing the daily activities are really important to this VE group. Myeloma disease-related factors. There were two factors. We measured quite a bit more than this, but there was two that were significantly higher in the VE group. That was their ability to concentrate and focus and severity of myeloma-related symptoms overall. All right, now we're going to go into conversations and family involvement. Who discussed these treatment options with you and how influential were these discussions in your treatment decisions? So other multiple myeloma patients, so their peers, was higher in that VE group at 1.5 versus 1.1. And if you look at the patients that rated this as somewhat influential, very influential, or extremely influential, that was 27%. So a little bit over 1 in 4 versus 17%. So a little bit less than 1 in 5 rated at that higher level. So talked with fellow patients. We asked the patients. I often ask for the opinions of other patients before making a final treatment decision. They could just check mark, I do this or do not. And the very extremely group did that 19% of the time versus 7%. And that ratio stayed the same for their most recent change, 16 versus 9%. How about family and caregivers? Here the question was, I discussed the options with my family or caregiver before making a final decision. And indeed, 49% of the VE or very extremely group said they did this versus 29% of the not somewhat group. This ratio maintained for most recent change at 48% versus 32%. So, well, now the doctor-patient communication and decision-making, we have this scale that we turn into a scale. It is kind of a continuous scale from 1, my doctor makes recommendations and I follow the doctor's suggestions, to 4, my doctor makes recommendations. I ask questions and we discuss my preferences, propose ideas, and I make the final decision. So you can see the VE group was 3.2 versus the somewhat slightly not group at 2.8. Now we did ask who really made that final treatment decision. In the VE group, 66, so 2 out of 3 patients, said I made the final treatment decision versus 52%, 1 out of 2, in the somewhat slightly not group. Here's the reciprocal of that, where the doctor made the final treatment decision, 34 versus 46%. Now, I should say in this question, there was a third option, shared decision making, but equally made the final decision. But interestingly, that was less than 1% of patients, so I didn't put it on the slide here. Now, the very extremely group did engage and use pharmaceutical companies' informational resources more. That was 23%, so about 1 in 4 patients, versus 11% or 1 in 10 patients in the slightly somewhat not group. Now, when you're quite concerned about the side effect profile of different treatments and you're really wanting to engage with more education, engage with more individuals about that treatment decision, you're likely going to need more time. And indeed, these patients were given more time, 4.8 versus 3.3 weeks, and they use more time to get to that final treatment decision, on average by about an additional week. So it's 2.5 weeks to get to that final treatment decision versus 1.4 weeks. Now, we did ask a question about trade-offs to receive a therapy. The question read as, in order to receive a treatment that may control your myeloma for at least 12 months, what are some trade-offs you would be willing to make? And interesting, so I have them all listed here. There's no observed differences, meaning that patients, if they need to make a trade-off, are willing to make it, regardless of the influence of the severity of side effects they may have in their treatment decision. We looked at clinical trial data that we collect in this survey. This analysis, the sample size is a bit low at 36 patients. So of patients that did consider a clinical trial for their change in treatment decision, but did not ultimately participate, again, that's a kind of a rare patient. And in this data set, there was 36 patients. In the V group was 15 patients, and 2 of them, or 9%, did not participate because they were uncomfortable with the possible side effects for the new treatment being tested. While in the slightly somewhat not group, there's 21 patients that met this criteria. They didn't report this as a reason. So, in summary, who are these patients that are very or extremely influenced by the side effect profile of the potential treatment options they're choosing between? They're proactive patients. They're highly informed, relapse refractory multiple myeloma patients who prioritize understanding and discussion of their treatment options. They're engaged with stakeholders, their providers, their peers, and their family and their caregivers. The time for the treatment decision is longer. Remember, is about 1 week longer to make the treatment decision, and they were granted more time to do so. Their personalized education matters. It highlights the importance of tailoring that patient education, focusing on their areas of concern. How is this treatment, availability, frequency, side effect profile, recovery time going to affect their quality of life and their responsibilities? Very important to these patients. And they have this higher shared decision making. They're So you need to support patients centered care for optimal outcomes. So here at HealthTree, I always like to turn the thank you around. The patients here at HealthTree, the volunteers, coaches, and employees at HealthTree, thank you, the audience, for your ongoing efforts to help find a cure. If you're a patient that's contributing to research here at HealthTree or other foundations, either through your data and participation or by a financial contribution. And for those employees working in the healthcare industry, providing those therapies to patients and help advancing cures. A deep thank you, heartfelt thank you here from HealthTree, as our mission is to help accelerate a cure. Thanks for listening today. And we have many other research projects, which I will hope be reporting on very soon. So pay attention.